Hello, everyone. Welcome to yours and my favorite part of the week. That's right, it is your online health psychology course, and I'm here to walk you through the hottest topics in social justice. That's right, if you like and subscribe today, we will end all injustice across this world. This chapter, we're going to review kind of some historical examples of kind of the connection between class or SES in health outcomes across multiple countries, so both historically and kind of more recent research. With all that said, let's jump into it. Beginning broad, social inequalities in health. Research has consistently shown that people of lower SES have more illnesses and lower rates of longevity than those in higher socioeconomic groups. There is a gradient, such as those who step down the ladder are unhealthier than those above. Gradient is often referred to as health gradient. So if you're not familiar or a little fuzzy on the term gradient, you can kind of think of it just like as a slope is kind of the most common way to think about it. And or like a ramp. So basically, the as you go down that slope or down that ramp or whatever down the ladder, you are at greater risk of negative health outcomes, both physically and mental health outcomes, if you are among lower SES. And now let's kind of walk through why some possible reasons and some kind of background literature demonstrating this. A French physician, Villermé, who lived between 1782 and 1863. In the 1820s, this physician examined the health of residents in different neighborhoods of Paris. This physician identified relationships between the wealth of a neighborhood and the health of its residents. Living in the poorer neighborhoods was associated with a higher death rate. Military conscripts from those neighborhoods were smaller and had more illnesses and disabilities. The condition of the working class in England was also examined in 1844. This book provided a detailed description of the appalling conditions and the limited health care of working class residents of Manchester, England. So really kind of now would be kind of a straightforward, and for many cultures it was. But at this time, we're really coming out of the, you don't need to know this 30-year war situation, which, by the way, based on Lord of the Rings, based on that, not the other way around. Just the kind of the modern nation states coming to existence. Countries are becoming increasingly more interested in kind of the health of their citizens and kind of what is impacting the health outcomes of their citizens. And this is kind of like that historical moment that we're kind of working through about 80 years into kind of the formation of the nation state or slash country. So anyway, kind of straightforward here, we see kind of a relationship between levels of wealth and kind of positive developmental health outcomes. And at the time, kind of looking for people to draft into the military or whatever, what the French physician identified was that there were lower rates of healthy conscripts slash like recruits or draftees from those neighborhoods, again, kind of reflecting their worse health outcomes. And then ultimately trying to figure out why. What is it about being poorer, especially during the 18th century, or sorry, I should say 19th century? What is it about that puts these people at greater risk of negative health outcomes? Jumping forward a little bit in time here to the 20th century in the UK, the National Health Service, the NHS in the UK in 1947 was an attempt to remove inequalities that existed in healthcare provision. Titmus, 1968, observed after 15 years of experience with the NHS existing that the higher income groups within their country, aka in the UK, they knew how to make better use of the services. They tended to receive more specialized attention. They occupied more of the beds in better equipped and staffed hospitals. They received more elective surgery, had better access to maternal care, and more likely to get psychiatric help in psychotherapy than low-income groups, particularly those in unskilled labor jobs. Hart in 1971 described these outcomes as the, quote, inverse care law. The availability of good medical care tends to vary inversely with the need of the population served. So again, without getting too deep into history here, we're post-World War II, UK has a lot of damage. So they are developing a healthcare system to try to increase health outcomes within their population. And then there's kind of a examination of, how the NHS, their national healthcare system, is doing 15 years later. And as stated, what they find is that Wealthier people have kind of a better understanding of how to use the services, and then consequently they are getting more elective surgeries. They are getting more attention. They're more likely to seek help and receive help. Now, this could be related to maybe increased levels of like education or kind of knowing other doctors, like wealthier people. You're going to consist of certain sets of professions, and then thus those people are kind of in your social network. So you have experience communicating with these people. You have familiarity with kind of the procedures, maybe the legislation, or just have kind of like personal connections that you can rely on to learn more about the NHS or just health services in general, and kind of advocate for yourself and thus kind of receive higher rates of care. Which brings us to this inverse care law. This is basically, you can think of this as a negative correlation. So for a classic stat situation here, when one variable goes up, the other one goes down. So in this case here, as needs increase in the population, the amount of quality, good, positive medical care decreases. So that's kind of the inverse. So needs increase, quality of care decrease is kind of this idea of the inverse care law. Moving on to the Black Report, which was a government report in the UK in 1977, establishing a working group to further investigate social inequalities in health. The Black Report, named after Sir Douglas Black, the working group's chair, summarized the evidence on the relationship between occupation and health. The report showed that those classified as unskilled manual workers consistently had poor health status compared with those classified as professionals. The inverse relationship between mortality and occupational rank for both sexes and at all ages. There was a class gradient, which was also observed for most causes of death, particularly respiratory and infective and parasitic diseases. Inequalities in terms of utilization of healthcare, especially among preventative services, were also apparent. So now we kind of have a breakdown of kind of different ages, sexes, and the occupational position of someone. And kind of as stated in the previous slide here, we see that unskilled manual labor, these workers are demonstrating or developing worse health outcomes and accessing these health services at lower rates. So this can be for a whole host of reasons. Maybe they are working more dangerous jobs. You can imagine like a coal miner or something like that, just making up something like that, or just in general, more dangerous jobs, exposed to more pollutants. They're probably going to live in worse neighborhoods, so thus have higher kind of rates of pollution around them in their neighborhoods, which we talk about later in future chapters. And at the same time, maybe having some kind of like stigma attached to utilize those services, which we'll get to later in this chapter. But maybe kind of the idea of like a working class background, I'm weak or something, or I'm like over relying on these services, and therefore I'm like a bum or whatever by utilizing these services, or kind of demonstrating some weakness or something along those lines by seeking the physical and mental health services. And also, in general, you have to kind of think of general fatigue or job burnout or something along those lines, wherein you come home and you're just kind of like, yeah, whatever. I'm going to come home. And especially in this period, well, TV exists, but not the internet. So come home, maybe chill, whatever, drink or whatever. And they're like, yeah, I'm too tired to go and do this research to try and figure out how this health system. I'm just going to come home, chill. It's more trouble than it's worth. Therefore, and that accumulates through time. Like you keep pushing, kind of utilizing health services, and then all of a sudden you get to X years old, where 50 years old, and wherein for all people you're at a greater risk for negative physical health outcomes. And those people in unskilled manual labor jobs are going to have a history of not engaging with these systems, and thus kind of their markers of potential health outcomes like early signs of diabetes or cardiovascular problems weren't identified early on. Those lifestyles then continued on, and now that person is like really, really at risk of developing whatever chronic health condition. You also see kind of with the parasite situation and respiratory illnesses, this again kind of consisting of or it could be related to lower class people living in, again, heavily polluted areas, much more crowded areas, and kind of just like more bugs or like rats or something along those lines, kind of just like spreading diseases among like a tightly concentrated amount of people. In understanding and dealing with health inequalities, it is important to recognize all determinants of health, from micro to macro, and to consider how many of these are within the control of individuals in society. Health inequalities can be considered from an ecological approach or systems theory approach. The ecological theory assumes that human development can only be understood in reference to the structural ecosystems. So this is kind of a Bronfenbrenner-esque situation. And you see kind of a lot of interesting research, like big research teams where you have like 10, 15 authors, because these guys, like kind of taking into account all these different structural ecosystems is very difficult, and you need a lot of specializations on your research team. But when you try to do so, you're going to have a ton of different authors bringing or researchers bringing kind of their specialties to try and identify these different determinants of health at macro levels and micro levels and some in between. But let's get into more specific. And that is, as stated, the Bronfenbrenner's ecological approach, who conceptualized developmental influence in terms of 4 nested systems. However, a 5th was later added. The microsystem, which consists of families, schools, and neighborhoods. The mesosystem, which consists of peer groups. The exosystem, which consists of parental support systems, parenting workplaces. The macro systems, consisting of political philosophies of a country, the social policies, the culture, and the chronosystem, consisting of the historical period. Now, kind of looking at these factors, these predictors within these systems, you can see that it's not always as clean. Like, there's not only like schools exist in the microsystem. Like, there are national school programs that impact the schools in the microsystem. So this is kind of just like all these kind of frameworks, kind of like a schematic that can be used, but ultimately these kind of microsystems and factors are all interacting with each other in dynamic, kind of complex ways, contributing to numerous developmental outcomes, and specifically in our case, kind of social inequalities in health. So Bronfenbrenner's kind of larger argument was that in order to consider any developmental outcome, again, in our case here, health, you have to consider these different systems. And these are just some of the factors like embedded within these systems, but ultimately taking into account the larger context in which a person is developing in order to understand predictors of health and why someone developed in a particular way, why someone developed a chronic, X chronic condition, why there are social inequalities in health. So psychology must be understood, according to Bronfenbrenner, within these overall developmental context, which consists of, again, these interlocking like web of environmental factors that we are all kind of implicated in. And it's not just that these factors impact us, but we also impact those factors. Like, for example, we already talked about like the NHS, and we'll talk about other US-based examples. NHS didn't exist forever. It came into being at a certain period of time. So we impact those systems impact us, and we are all impacting each other. And it's a beautiful, wonderful circle of life. The accumulation of adversity, low SES, accumulate across all ecosystems. This accumulation and clustering of adverse physical, material, social, and psychological effects could explain the health gradient. While each factor alone could be expected to produce a relatively modest impact on mortality, the combination and interaction of many kinds of ecosystem disadvantages are likely to be sufficiently large to generate the observed gradient. So one of the big things kind of in stress researcher is kind of this idea of accumulation of stress. And kind of the idea here is that no one individual factor or stressor or whatever adversity is going to just derail your entire life in generally speaking. However, it's the accumulation of these stressors that come together to kind of predict negative health or any developmental outcome. So basically, looking at one single factor, the argument is it will always yield kind of like a small effect size. So as such, you need to look at the total, some measures of cumulative stress, that accumulation of adversity, because not just for statistical reasons, because again, like when you have those kind of composite, those accumulative measures, it basically gives you more statistical power to find significant results for whatever statistical reasons. But at the same time, the accumulation of a model of stress or adversity is argued to be more ecologically valid, aka kind of more kind of real, like more based on kind of like the hashtag lived experience of people. So kind of think this through. Most people in general who are in like low SES, they're not just experiencing like one stressor. They're experiencing multiple stressors, and all these kind of stressors and adversities are coming together and accumulating within a person to negatively impact them. So thus, it's not really, they make the argument that thus kind of looking at only like one single stressor is really not an accurate portrayal of the stress that a person experiences. All these kind of stressors are always going to be inherently correlated, because once you're kind of in a poor neighborhood, you're going to have higher rates of violence, lower rates of quality food, less quality education. All of these things kind of go in hand. They kind of quote unquote naturally, but whatever. They exist in our social world, current social world. Those kind of contexts, those environmental factors are going to be correlated. There's very rarely places of like a very, very poor neighborhood that's like, okay, yeah, we have very low quality schools. We have very low job opportunities. We have, but we have like the greatest grocery stores ever at like a great price. Like those, like there's rarely like this spike of like these other random like incredibly institutions with like a ton of resources. It's usually in general kind of like a collection of underfunded institutions and stressor within a population. And as such, using an accumulation measurements of stress is a more kind of accurate, valid assessment of the challenge, the inequalities faced in certain populations. And kind of referencing the Bronfenbrenner model, you could see, you can imagine that, again, kind of like a very adverse neighborhood, they're going to have, in the microsystem, maybe very stressed out parents. So maybe thus the household having higher rates of mental health disorders or other chronic conditions. Again, kind of lower quality schools, more stressed out teachers, less resources within a school. And then looking at like the exosystem, the parental workplace, the parents probably have little control over their job, maybe getting paid less, kind of feel like they're kind of in a dead end situation. It's like the classic like 9 to 5 and you're just sitting in traffic. Like, what am I doing in my life situation? So you can see kind of those, that low SES accumulating and kind of bleeding across all those different ecological systems. And if you want to get into statistical terms, clustering together. Now, one way that you can measure the accumulation of stress is through something called allostatic load. This, broadly stated, is defined as, or operationally defined as, the active ongoing maintenance of internal equilibrium, which increases allostatic load, which reflects the chronic wear and tear on the body caused by the mobilization of resources to meet changing environmental demand. So kind of what we talked about early on in this class, we have this idea of an equilibrium, homeostasis going on here, and in response to our environment, we have various physiological responses. And kind of the idea of allostatic load is attempting to measure the wear and tear on a biological level of these stressors. So it's kind of chronic wear and tear on the body, and there's what is going to happen here is this is going to be a composite measure, which aims to, again, measure the physiological impact of this chronic wear and tear of living in a stressful environment. So indicators of allostatic load include resting blood pressure, overnight cortisol levels or norepinephrine levels, an index of fat disposition, and ultimately a total allostatic load index ranging from 0 to 6, reflecting the number of these 6 singular physiological indicators on which a child scored in the top quartile of risk. So kind of in English here, we have this construct called allostatic load. It's meant to measure the accumulation of stress and how that's impacting us on a physiological level. So what researchers do basically is have, there's not just one way to measure allostatic load. For our purposes, though, we're going to have an allostatic load where there are 6 measurements. One could be elevated blood pressure or high rates of stress hormones, what you wake up to, in the morning. And ultimately, what researchers are going to do is measure your risk across those 6 different markers. So, for example, I measured your blood pressure and you have extremely high blood pressure. You're in the top quartile of risk. That's 1 for your allostatic load. Next, I measure your overnight cortisol, say is very, very high. You're in the top quartile of risk. Now your allostatic load is 2. Then I measure your BMI or fat disposition. There's again multiple ways to measure this. Say it's in a top quartile of risk. Now your allostatic load is 3. And kind of the idea here is as that allostatic load increases, that is a marker again of kind of the chronic wear and tear of your system. This is a physiological, biological indicator of stress wearing you down and how it's impacting you. It's called how stress gets under the skin, again, at a biological level, wherein, again, the higher allostatic load, the greater risk you are of developing chronic conditions or early mortality. Now let's look at a specific study wherein the researchers measured the correlations or predictors of high allostatic loads. Beginning with Evans, 2003, whose name is Gary Evans, very, very, very famous chronic stress researcher. This is all what I said before about the arguments for chronic stress and how you really shouldn't just be measuring a single stressor, but the accumulation of stress. This is basically all his. He was foundational to making these arguments. He's a researcher out of Cornell. Gary Evans, not the serial killer, Gary Evans, but the Cornell professor. So if you Google Gary Evans, you're going to get serial killer, but no, the other one. Anyway, study on allostatic load. Evans in 2003 found that physical, aka crowding, noise, housing quality, and psychosocial, child separation, turmoil, and violence, aspects of the home, environment, and class characteristics such as poverty, single parenthood, maternal high school dropout status were cumulative risk factors. Elevated cumulative risk was associated with heightened cardiovascular and neuroendocrine parameters, increased body fat, and a higher summary index of total allostatic load. Previous findings suggest that children who face more cumulative risk have greater psychological distress, were replicated among a sample of rural U.S. children and shown to generalize to lower perceptions of self-worth. So in the sample, Evans is measuring the rates of cumulative risk factors within a U.S. rural population. So again, the risk factors that he's focusing on are physical, so it's like housing quality, noise is kind of a big one for him, crowding, and then psychosocial, so maybe child separation, maybe violence in the household, or kind of just general kind of instability in the household, and then poverty rates. So looking at these kind of cumulative risk factors, so accumulation, adding them together, and you can think of them kind of like allostatic load. So again, if a person has or a child, or this rural child lives in a area with or a house with a lot of crowding, that's 1. If they live in a house with a lot of noise, that's 2. If there's a lot of violence in the household, that's 3. And so it's a cumulative risk factor. And then what Evans found was that accumulation of risk factors was positively correlated with the total allostatic load. So in other words, the more cumulative risk factors that a rural child in the U.S. Experience, the higher their total allostatic load, the higher their physiological risk. Again, the higher rates of their cardiovascular risk, higher rates of their body fat risk, higher rates of cortisol risk. So we have a positive correlation between allostatic load, that measurement of chronic wear and tear, and this cumulative risk factor. All right. So an example of how you can use allostatic load as a physiological marker, a biomarker, or allostatic load as a biomarker, demonstrating the impact on just not like a social level or how you think you feel or whatever, or just kind of general understanding of the impact of cumulative risk factors, how stressful that is. You can measure this at a physiological level. Now, interesting as well is that children who had higher allostatic loads and cumulative risk factors, that was also associated with lower levels of self-worth. So I feel like I'm a lower quality person. I don't deserve things in life. I'm not worthy of whatever. I'm going to accomplish nothing in life. So that living in kind of very unstable environments associated with that lower self-worth within that rural U.S. population. Now, there are other kind of cumulative measures of physiological outcomes associated with stress. Another big one is called weathering that you might be interested in. There's great research on this as kind of like the impact of weathering. So you can kind of think of like a storm or like an ocean just like pounding a rock and through time kind of eroding the rock. There's good research on kind of that weathering effect, which is very similar to allostatic load on health outcomes in Black U.S. Women and men, and kind of using that kind of weathering approach to explain discrepancies in health outcomes among races within the United States. Moving on to our old friend, the health onion, a general system framework for understanding determinants of health and illness. Of key importance is the perceived environment, not only the so-called objective environment. Wilkerson and Pickett in 2010 hypothesized that the structural inequality in society causes people to become more anxious, stressed, ashamed, untrusting, and unhappy. So kind of like the Bronfenbrenner model, we have kind of the health onion uses not just kind of like quote unquote individual life factors, but also social community networks, SES, culture, other kind of broad macro environmental conditions and how those are implicated in social inequality or health outcomes. Now, kind of going to this objective environment point without going into a lot of detail here, because I can talk about this all day, kind of the idea here is that people, Wilson and Pickett, are arguing that it's not just kind of the objective existence of poverty that is the issue, but also kind of your subjective interpretation of your environment. So, for example, say you're like a poor person now, you're in the U.S., you're in the Evans sample. You're in the rural U.S. Those people are not unaware that rich people exist, that there are other places in the country wherein there's higher quality food, less kind of home turmoil, less crowding, less noise, higher quality of like housing. They're not like, oh, I've never heard of that before. No, they are actively aware of it, and thus can compare their life to like other people's lives. And then one natural question is like, oh, why is my life like so much more hard than this hypothetical other person's life? And kind of a common conclusion is that, oh, I've done something wrong, or maybe the people around me have done something wrong. But ultimately, that can contribute to kind of increased feelings of shame or like kind of general alienation, kind of lacking, increasing or decreasing stress or trust, I should say, decreasing trust within the neighborhood, maybe decreasing trust of like the federal government or something like that. Like, oh, how did this person happen to me? But ultimately, kind of more stress, more unhappy, greater levels of anxiety. Maybe because, once you think, that it's your fault or people around you's fault, it's like, well, then it's I therefore have to make and then have like this very individualism mindset. It's like, well, then I have to individually like kind of grind my way through this, and that just puts a lot of pressure on you. That makes that can increase anxiety. Because you're facing a lot of challenges and kind of everything is riding on your individual choices and behavioral lifestyle choices, as evident by like, oh, those other people exist. Why do they have it and I don't? I don't know, because it's my fault. It's kind of the idea here. Very much wrapped in kind of the Protestant work ethic thing that we'll talk about in kind of like future chapters, how that's kind of like impacted kind of cultural understandings of health and frankly all developmental outcomes. All right, moving on to some psychosocial examples. They are considered at the micro, that is the individual, and social macro levels. At the micro level, it is argued that cognitive processes of comparison, in particular perceived relative deprivation, contribute to heightened levels of stress and subsequent ill health. At the macro level, psychosocial explanations focus on impairment of social bonds and limited civic participation, social capital that flows from income inequality. So basically, this is what I already discussed before. So at the micro level, kind of using that cognitive process of comparison, understanding that other people exist that have it better than you. And then, okay, so how do you process that? What is the conclusion on why? And basically, your conclusion is going to impact how you evaluate yourself and your other people and other people around you, and can increase stress. And then kind of at the macro level, kind of decreasing social bonds. So again, kind of like I'm alienated from society. I'm not going to participate in any like civic responsibility or maybe follow world events, maybe less or something along this, because ultimately like it may not actually matter at all. you don't care about me, I don't care about you, and we're kind of just I'm just drifting through and kind of just drifting through life, or just really trying to kind of just survive through life. Is kind of like some possible interpretations of the psychosocial element of kind of like deprivation at a micro and at a macro level. Neo-material explanations focus on the importance of income and living conditions. At the micro level, it is argued that in more unequal societies, those worse off have fewer economic resources, increasing vulnerability to various health threats. At the macro level, high income inequality contributes to less investment in the social and physical environment. Those who favor the neo-material explanations argue that the psychosocial explanations ignore the broad political context within which social and health inequalities are nested. So I'm not really sure exactly why they call themselves neo-material. This just sounds like a historical material analysis that's existed for hundreds of years. But it could be due to changes in the economy kind of moving away from industrialization, but that's kind of a side point. But so what the neo-materialists are arguing basically is that, listen, the psychosocial things exist, right? Like there are cognitive processes that occur. There are social capitals, kind of a thing that exists. There are social bonds that exist, aka the quality of like social relationships among people within a particular context. Again, these kind of internal cognitive processes of comparison are going on. However, those things are not just existing in a vacuum. And basically what they're arguing is that psychosocial explanations, and often kind of like psychology as a whole, is kind of just looking at these social processes, these cognitive processes kind of like in a vacuum. That is, people kind of like individually coming to these conclusions, individual sets of cognitive processes that exist that may be distorted for some reason, and then therefore you got to engage in cognitive behavioral therapy or something like that. Or you maybe have like a unstable household, like whatever you need, marriage counseling or something like that. So basically, so in that context, it's kind of like very much like in that micro system level, looking at kind of again individual processes cognitively in social bonds. But what the neo-materialists are arguing is like, yeah, those things exist, but you have to place them within a larger context, a social and health, because adverse factors are nested. They are clustered among certain populations and exist within particular social, socio-historical, and political context. So kind of as such, you can't just like take just imagine some person from some poor country and you're like, oh man, you have distorted views of yourself. Your self-worth is too low. That's so distorted. And then like just try and just help that person just reframe their cognition in the absence of increasing economic resources and investment within that person's neighborhood. Because ultimately, that person, after that therapy session or whatever, is going to go back home. They're going to live back in that environment and again face those accumulating stress factors, which again have been shown to be associated with higher levels of allostatic load. So as such, you kind of looking at those social processes or cognitive processes in the absence of those of increasing economic resources in decreasing income inequality. Without doing that, the person will not benefit from whatever the therapy or whatever program or whatever cognitive reframing that's happening at the highest level possible. And from like a kind of a preventative health kind of standpoint, the way to address the whatever higher allostatic loads or which are associated with chronic conditions is to literally just recreate different environments. So they're basically arguing that you're kind of like downstream from the larger structural issues that need to be resolved, and you're kind of missing the forest from the trees situation. You're missing the broader social, historical, political, economic context that we're living in, which is actually shaping those social bonds, that civic participation, that sense of self-worth, that cognitive processes of comparison. And again, use a big when these kind of neo-materialist explanation research design is kind of implemented, you see kind of very large research teams because you need people kind of from different expertises. Now let's talk about how regular people, that is lay people, think about health. Calnan in 1987 conducted a qualitative study with working class women in England. Working class women were reluctant to accept that they were less healthy than middle class women. Professional women were more likely to accept the existence of a health gradient. Blackster in 1997 conducted a secondary analysis of a large survey of British health and lifestyle. Limited evidence of popular discussion about health inequalities, especially among people from poorer backgrounds. So this is a little initially kind of counterintuitive, wherein the working class women in this English study were less likely to accept kind of this idea of health gradients, aka kind of like as you go up in the SES, you have better health outcomes. This could reflect a whole host of things that are happening in 1980. Maybe kind of like the internalization of this idea, very kind of that you're responsible, kind of a consumer responsible kind of framework, wherein you're responsible for your own choices, and therefore it's kind of up to you. So kind of very much like an internalization of that kind of larger cultural explanation for health comes. And maybe kind of more middle class or higher class women having higher access to educational materials, wherein like these kind of research is discussed or something along those lines. So kind of being maybe more familiar with this research, and thus having the greater kind of cultural access. It's you don't need to know this term, but cultural access, like cognitive access to literally that way of thinking. Like if you've not really heard of those explanations before and are kind of in a culture that really doesn't emphasize it, then you kind of have little kind of cognitive access to that information or that way of thinking, that framework. So kind of literally like beyond like your consciousness kind of a situation, because you weren't taught it. You're not exposed to those kind of cultural messages. One possible interpretation of this. Next, another lay explanation from our cousins up in Ontario, Canada. This is a 2014 telephone survey study where respondents reported they were most willing to attribute income-related health inequalities to differences in employment, social status, income, and food security. Respondents were less willing to attribute inequalities to differences in early childhood development, social exclusion, the social gradient, and personal health practices and coping skills. So in here, this survey, these in Ontario and published in 2014, but the survey was conducted in 2006, found a kind of very neo-materialist explanation among these participants, wherein they're basically saying, oh, we have their health inequalities exist because we have differences in employment, aka you have a higher paying job, maybe you have access to supplemental health care through your job that I don't. You get paid more, so thus you can live in different neighborhoods. We can afford better food. I don't have to worry about people in the higher SES don't have to worry about not having enough food for their family or something like that. So they have higher rates of food security and kind of overall social status. So like saying, for example, like I'm introducing yourself as doctor whatever, that automatically like to trigger something in people to say, oh, that person is distinguished. They got their shit together. They're professional. They have a lot of kind of social prestige associated with them, which in return, people will kind of treat you a little bit different if you say you're doctor whatever versus like I'm, whatever, cashier or something like that. Quite common in kind of customer service or whatever. But the respondents were far less likely to report coping skills or personal health practices as kind of the reasons for inequality. So again, kind of going back to maybe that cognitive behavioral therapy kind of thing, like, oh, I just have to cope differently with the poverty and therefore I'll have better health outcomes. Or I just have to individually eat differently or something like that. So less likely to kind of report those kind of individualism or individualistic kind of lifestyle choices and kind of cognitive reframing kind of things that are kind of classic, classically, but I guess more contemporarily associated with psychology. Our authors argue that social justice is a life and death issue affecting the mental and physical well-being of billions of people. According to Dahlgren and Whitehead, 1991, health inequalities can be considered as inequities when they are avoidable, unnecessary, and unfair. Daniels et al., 2000, argued that adhering to John Rawls' underlying principles of a just society would address the basic social inequalities in health. So basically, what this is going to get at as health inequalities exist. What do you do about it? What are avoidable? What are quote unquote unfair and unnecessary? And this is going to get involved in like philosophy or different economic and kind of political views. And these people are going to basically make an argument of what health inequalities are, again, are quote unquote unnecessary and unfair. And this person is going to rely on this kind of famous within the field researcher Rawls, which is going to who kind of laid out principles of a just society. So let's review those. So Rawls argued that that a society should assure people equal basic liberties, including guaranteeing the right of political participation. He argued this will contribute to improvements in health, since, according to the interpretation of social capital theory, but political participation is an important determinant of health. Societies must provide a robust form of equal opportunity, things such as childcare, childhood interventions to combat any disadvantage of family background, comprehensive health care, especially for disabled people. So this is kind of like classic kind of conclusions coming out of like the Enlightenment period, whatever. Basically what they're arguing here is that, or Rawls is arguing that equal opportunity and kind of equal basic liberties within a country will increase health outcomes because if you're literally not allowed to vote, you are maybe more likely to have like a negative evaluation of your self-worth. You're probably going to be disenfranchised in other ways, have less like whatever economic, educational opportunities, something along those lines. So as such, like having basic sets of equal basic liberties is kind of required for positive health outcomes. And then kind of this equal opportunity situation here. So maybe something like in the US, something like food stamps, something like that, WIC. Head Start is another classic one, basically identifying children who are at from adverse backgrounds at an increased risk of negative developmental outcomes, and kind of equalizing, I guess, kind of the playing field, or increasing the likelihood of equal opportunity through these kind of federal or state programs is basically the argument. All right, moving on to a 2017 conference, psychological conference. The president of this psychological society, the BPS Society, the British Psychological Society, this president Kinderman argued that psychology is action, not thinking about oneself. He called on psychologists to, quote, speak out against those social, economic, and political circumstances that impact our clients and the general public, and to bring such evidence to politicians and policymakers. So kind of pausing there, kind of in kind of the pop psychology or general kind of way about thinking about psychology really often involves just thinking about yourself. Like, why am I like this? Why is my family like this? Or something like that. And here, this the president of society is basically arguing, no, psychology is action, and not just kind of thinking about yourself, but rather kind of the environmental conditions that we develop in. We all have an understanding that environments impact us. Let's kind of expand what that environment, or maybe specify what that environment means, and also from a health perspective, kind of work to speak out against these inequalities within environments, and work to change it in some ways. He says bring it to the policymakers is his argument, which assumes a lot about policymakers, but it is what it is. So need for what Horrocks and Johnson have described as a socially situated approach to promoting health and preventing illness. They argued that continued focus on individual behavioral change strategies in the absence of change to other environmental factors in the Bronfenbrenner model will maintain the status quo and contribute to victim blaming. So as we already talked about here, the idea of the Bronfenbrenner model, here we have a term called socially situated. That is, you exist within a context, your developmental outcomes, your health outcomes are going to be influenced by that context. That is, we all people, all human beings, everybody is socially situated. We grow up in environments. We are a mega social species. We are whatever, going back to the Bronfenbrenner model, interconnected, interacting with each other in dynamic ways to impact our developmental outcomes. Therefore, kind of just focusing on specific individual behavioral changes, which can be useful. It's not that, oh, this is like bad or whatever. But in the absence of working to change or kind of at least researching these other environmental factors, you are really not going to get that far in kind of preventative healthcare because, again, kind of the argument is that those environmental factors are going to increase allostatic load, increase the levels of exposure to cumulative risk factors, and thus you kind of have to address those things and at the same time contribute to victim blaming. So if it's an individual, if you're only focused on the individual behavioral change, it's not a that far of a logical leap to say, okay, well, because it's an individual lifestyle issue, it's your fault. Because you elected not to eat healthy or something along those lines. We all are rational human beings. We all have equal access or opportunities to make a choice. You chose not to. Therefore, their argument is this is contributing to victim blaming and probably at the same time kind of internalization of that victim blaming, which we talked about before, wherein you accept that, oh, it is only individual lifestyle factors that impact health. Therefore, it is kind of my fault. I had the choice. My people around me had a choice. This is our choice, and therefore we screwed up. And now I have decreased self-worth. It's kind of a rough argument or interpretation of this argument. Moving on to the universal right to health, human rights refer to the fundamental moral and legal social norms necessary for people to live a minimally good life. This framework argues every person is entitled to human rights simply because they are in fact a human. In 1946, the World Health Organization first expressed the right to health as a fundamental human right. Article 25 affirmed that human right to a standard of living for adequate health and well-being through the provision of food, clothing, housing, and medical and social services. And the promotion and protection of these rights are prerequisites to a dignified, free, and secure way of living. This framework argues that the right to health is intrinsically linked with other civil liberties and freedoms. They consider the effects of human rights violations, slavery, genocide, ethnic cleansing on the health and well-being of its victims. So in the 40s, really, again, coming out of World War II, where you get the development of these new international institutions that kind of exist with today for us, where they lay out during this time, they're creating new institutions. They're basically creating the Human Rights Charter and all these other things. And the World Health Organization then creates a document wherein there's a lot of articles, and Article 25, again, kind of reflecting the idea that that our environmental conditions impact us, and adverse environments increase the risk of allostatic load and negative developmental health outcomes. So kind of reflecting that research, or the research ahead of the time, they basically make the argument, well, if people have a right to health, and therefore these conditions are going to predict or influence or cause, depending on your interpretation, negative health outcomes, then these structures must be changed. And at the very least, these kind of basic standards of living must be met in order for people's human rights, aka their right to health, to be fulfilled through food, clothing, housing, medical, and social services, for example. And at the same time, these kind of greater injustices, these huge human rights violations, slavery, genocide, whatever, is going to needs to be addressed, eliminated, because it's not just that you're immediately dying from these atrocities, but also kind of the historical legacies for those populations who are exposed to those kind of severe human rights violations. So those human rights violations are violating someone's fundamental right to health as a human. Stigma. Stigma refers to unfavorable reactions towards people when they are perceived to possess attributes that are denigrated. Healthcare professionals are as likely to stigmatize as any other group, influencing their behavior and decision-making in the provision of healthcare. Consequences of stigma include physical and psychological abuse, denial of economic and employment opportunities, non-seeking or restricted access to services, and social ostracism. So there are kind of many different ways that stigma can play out among, for example, a patient and a healthcare provider. But kind of interpreting this a little bit, you can imagine, again, going back to kind of like a very individual-based framework wherein it's that individual's life choices that cause that person to have kind of some kind of, be at risk that's of a negative health outcome, or maybe that's why they're there today, because it's like, oh, you chose to do this for X amount of years. And it's like you're thinking, or makes you prone to thinking like, oh, what a fool! This person is less than me. They are not as like forward thinking as me, and that kind of framework, that way of thinking, can kind of reduce the quality of care provided to a person. It can also maybe increase the likelihood that you overlook certain symptoms, or you disregard the patient's kind of opinions, what they're telling you, and you're like, yeah, this person doesn't know what they're doing. They're they're always making poor decisions. They don't know. They clearly don't know, or they wouldn't be here. I'm the professional. I'm going to tell you what to do, or I'm not gonna look into that symptom. You know what you're talking about. So thus you kind of a restricted access to services. And kind of one argument in a recent book is Dr. Blackstock out of New York University, who a black female doctor who kind of looks at health outcomes among black women, and basically she a pretty recent book, it just relatively recently came out, and basically she highlights kind of the history of even just kind of like more pop examples, pop culture examples of even wealthy black women who report symptoms and then are kind of just like disregarded through time. And then all of a sudden, they're 40, 50 years old, and there's like this mass like health risk wherein they almost die because their kind of concerns or kind of their reported symptoms were kind of just ignored through years of time, which obviously puts those people at greater risk. And basically the argument is just like that level of wealth can put these people at risk. Imagine what happens to people with far less like cultural cachet and less economic resources. Next, let's look at an action research study from Guatemala, from Ley and Rato Barrio, and from 2013. It was called let's go for it, people, Acción Psychosocial a través del movimiento juego y deporte. Yeah, pretty bad, right? Yeah, pretty awful. I only took 5 years of Spanish. Anyway, this stands for psychosocial action through movement, play, and sport. And that, folks, is on having a Puerto Rican family household that never spoke Spanish. Proud legacy. Anyway, this is based in a rural area of Guatemala with two groups of women who had suffered from violence. Psychosocial and participatory approach to develop the use of sports and games as educational and therapeutic tools. And as you may recall, hopefully, action research kind of methods involved researchers kind of working with the community to identify predictors, problems within that community as reported by those community members, and then the researchers working with the community to design interventions to change their environmental conditions and improve the developmental outcomes within that community. So in this case here, we have researchers working with women in Guatemala who lived in a rural area and who had suffered or previously suffered violence. And they are going to design a sports and kind of gaming kind of groups as a form of therapeutic tool. Results from the research suggested improvements in a sense of coherence and self-esteem among participants. The program provided opportunities for women who suffer from violence to socialize and offer mutual support. The group also facilitated group interaction. It enabled participants to share their experiences of violence and domestic conflicts in a safe and protective space. They were able to express their feelings and to explore potential solutions with others. This process contributed to mutual learning and enabled participants to reconstruct their perceptions of the world and to reflect on how their circumstances could be improved. So here we see is this group design or this action research method wherein they use groups as an opportunity for social engagement, play through sports and games, and educational and therapeutic tool. Just kind of stopping there for a second. Often, especially kind of in the West, you see that therapy really thought of as like this one-on-one situation. That is not kind of universally true. In fact, research suggests that in some cases, like there's classic examples of where wherein a population is impacted by some kind of large either political violence or natural disaster. And mental health professionals, quote unquote, on the ground will maybe separate the child or the mother, father, or whatever for some kind of individual therapy session. But what that actually ends up doing is it kind of increasing stress and decreasing the coping process, the healing process for that population, because you're literally kind of taking away their social network and separating them, which is kind of like not consistent with their culture. So in this case here, this is kind of an example of like kind of a group, a therapeutic kind of session, or kind of a group game, something, but ultimately a collective approach to working with this group of women who were exposed to high rates of violence. So it kind of increased self-esteem and kind of that sense of coherence, aka kind of the degree to which kind of life makes sense and is understandable for people. So really kind of comprehending your circumstances, managing it, and increasing meaning making. These are all kind of, again, we've talked about meaning making before, and we'll talk about it later on in this class, definitely a predictor of health outcomes. So through this kind of facilitated group interaction, people are sharing their stories. It kind of a protective area among people that have similar experiences as you, and kind of which allows you to express your feelings, and also at the same time, again, in this action research method orientation, looking to explore potential solutions to the hardship that they collectively have faced. For example, kind of discussing what are some predictors of violence or kind of domestic turmoil within the household, and then working as a collective towards, resolving or dealing with those predictors. And now wrapping up our stigma kind of right up here. Stigma is often a powerful predictor of social control and exclusion. By devaluing certain people, society can excuse itself from making decisions about the rationing of resources, services, research funding, efforts, and care to these groups. Stigmatized people frequently expend considerable effort to combat stigmatization and manage their identities, including passing, that is, acting as if they do not have the stigmatized attribute, covering, de-emphasizing differences, or resistance, speaking out against discrimination, and withdrawal. At risk of internalizing the stigmatization, well said, feeling considerable guilt and shame in devaluing themselves. Katiansky argued that coping with stigma could be seen as a meaning-making effort to enable those who are being stigmatized to transform the way they see themselves and to orient themselves in society. So kind of the idea of stigma, according to this argument, this frame, is that, again, stigma does not exist in a vacuum. People who are going to be more likely to be stigmatized are those who are either historically or contemporarily more disenfranchised from society. So kind of the argument is this is kind of a method, a social mechanism of control and method by which some groups are excluded. And at the same time, because if a group is stigmatized, again, that group has made their own decisions. We all had the opportunity to make the same decisions. Any developmental outcome, health outcome is going to be solely because of an individual choice. That group clearly can't make correct choices. Therefore, I am correct in my devaluation of that group, and therefore I'm also correct in not investing socially, culturally, economically within those communities. And in light of that stigmatization, people who are stigmatized aren't like, well, I didn't know I was stigmatized. They're well aware. And there are multiple ways to kind of deal with that. Those include passing, so, acting like you don't have the stigmatized attribute. So, I don't behave that way. I don't talk that way, unlike those other people who are part of my group. Or saying like, oh, our group differences aren't that really that different. Or at least like the group differences aren't that meaningful. You can also kind of just like withdraw from society, or resistance, aka speaking out against it, or I don't know, doing something about discrimination. But ultimately, our author Katiansky, 2014, arguing that coping with stigma, dealing with it, could be a way, a meaning-making effort wherein you make sense of like your group's history, your own place in the world, your own feelings, your own developmental outcomes, and thus with that meaning making, maybe having a framework by which you can work to kind of transform your how you see yourself, combating that internalization of stigma, and maybe transferring the society so that stigma doesn't exist. Life's worth living versus the right to die. The right to die debate revolves around the argument that people with severe or terminal illnesses and people with disabilities have the right to end their lives when they feel they have become unbearable, and that assisting them to do so should not be illegal. The argument against the right to die lobby, although implicitly anti-suicide, is not necessarily about whether suicide is right or wrong per se. Authors argue this should be viewed as being about the differential treatment of the issue for people with disabilities and severe illnesses as opposed to quote-unquote healthy people. All right, so let's unpack this a little bit. The idea of right to die is that if a person has some kind of severe terminal illness or some disabled person, they should have the right to end their life. It's control of their like body or whatever, and therefore they have the right to live. They have the right to die. Is kind of the argument. Now, there is a critique of this, but not from the direction that you're probably thinking, and that is that one argument is kind of from a disability advocate perspective, and that is they're not arguing necessarily that a person should not have the right to die, to end their life when faced with terminal illnesses or have a disability. But rather, they're kind of pointing out that they're making the argument that there are kind of limited resources for disabled people or people with kind of terminal health conditions. And so kind of what they're arguing is that at the same time that limited resources are available to disabled people, and there's stigmatizations and there's kind of lack of access for disabled people across schools, jobs, employment opportunities. This combined with a right to die is basically saying, okay, we're going to give you nothing, but we're also going to give you the opportunity to commit suicide. So kind of the idea here is that disabled people have differential treatment, aka more disenfranchised treatment throughout their entire lives. Then because of that disenfranchisement, that social ostracism, that alienation, those people are going to have be at higher risk of low income, living in poverty. Homeless people or disabled people are at higher risk of being homeless. They are in kind of in collectively then just a greater risk for negative developmental outcomes, including like suicide ideation or just not wanting to live. So basically their argument is like, hey, you're kind of like socially dislocating, isolating these people, or abusing these people their entire life, and then kind of your solution is like, okay, well, if you want to, you can kill yourself at the end of your life. So basically what they're arguing is that yes, a right to die is good or whatever, moral or should be advocated for, but you cannot have that in lieu of other investments in kind of cultural transformations and how we view and treat disabled people. Otherwise, you're just going to have certain historically oppressed and disenfranchised groups exercising their right to die by committing suicide at higher rates. So kind of a life of injustice, and then at the end, just giving them the option to kill themselves. It's kind of the argument. Dahlgren and Whitehead, 1991, identified 4 different levels for tackling health inequalities. They include strengthening individuals, communities, improving access to essential facilities and services, encouraging macroeconomic and cultural change. They argue that efforts directed at individual level have been inconclusive and too small of scale. So this is basically more or less consistent what we've already talked about here, and have their own 4 different levels of tackling inequality. You see this often in social sciences and all sciences, frankly, of kind of different frameworks with kind of minor differences, but sometimes they have kind of different theoretical orientations to resolving these inequalities, which can be implicated in why there are different frameworks. So these researchers argue that since many health determinants are beyond the control of the individual, psychological interventions aimed at individuals are likely to have limited impact on public health problems when considered on a wider scale. There's need for psychologists to work beyond the individual level with families, groups, work sites, and community groups. Structural changes at society level are ultimately required if the prevalent inequities are ever going to be reduced. So basically, the argument is that because health determinants exist at all levels of Bronfenbrenner's model or the health onion, whatever framework you're using, psychological intervention at individual level are going to kind of by definition have limited impact. It's not that they're worthless, don't do anything or whatever, but like they are those developmental outcomes are going to be influenced by, again, these kind of larger networks of environmental factors. And as such, when kind of designing public health problems, you can't just say like, oh, well, we're going to one by one, kind of individually for billions of people, give them an hour of therapy or something like that. Not saying, again, the argument is not that necessarily that's wrong, but kind of in the absence, again, of these kind of larger changes to communities, work sites, families, whatever macro thing, this is going to be a feeble effort and ultimately an unsuccessful effort, according to research demonstrating that higher SES or greater inequality or oppression, social isolation, alienation are going to increase the risk of negative poor mental health and physical health outcomes. So thus, you're kind of you're treating the symptoms of a larger issue and not the cause of issues. Or in other words, Band-Aids can't fix bullet holes, as our great philosopher T. Swift once said. Some other limits of individual change include people living and working in disadvantaged circumstances have fewer resources such as time, space, and money with which to manage the process of change. Health-threatening behaviors such as smoking tend to increase in difficult or stressful circumstances as they provide a potential means of coping. There may have been a lack of sensitivity to difficult circumstances in which people work and live that constrain the competence to change. It also there's a tendency also to blame the victim. So basically, the argument here is that even with people, it's not necessarily that individual does not want to change, is that they have the difficult circumstances in their life means that they have fewer resources. That is, social resources, temporal resources, aka time. They have less money, financial resources to manage the process of change. That can take a lot of time and a lot of money. So expecting people to individually go about, give them advice, and then just have them fix it themselves is kind of not realistic, is the argument. And moreover, quote unquote, unhealthy behaviors are allow for many people to like survive during the day. Like a person who has a chemical dependency on whatever cigarettes, alcohol, or whatever drug, maybe it allows them to just keep grinding throughout the day. Now, is those circumstances ideal, healthy? No. And is that choice the healthiest choice? Maybe not. But it is kind of a choice that allows them to keep kind of grinding through difficult circumstances in their life, is basically the argument here. Next, we have social capital. This is a term coined by Putnam in 1993, who argued that certain communities and higher degrees of civic engagement, levels of interpersonal trust, and norms of reciprocity. Together, these characteristics contributed to a region's degree of social capital. He argued that over the past generation in the U.S., there's been a steady decline in participation in social organizations and thus a steady decline in social capital. Bridging social capital refers to links with diverse groups and provides an opportunity for community members to access power and resources outside their community, while bonding social capital refers to inward-looking social ties that bond the community together. Campbell, 2024, stressed that both forms of social capital are essential in building healthy communities. All right, so there are a lot of different definitions of social capital. We're just going to take this one and ride with it, or we'll be here all day. So basically what we have here is Putnam arguing that social capital, you think of capital as like money, investment, whatever, finances, but in a social form. So you have a lot of social capital that you can invest, that you can use to leverage whatever. Just think of capital and just make it social. So in this case here, we have high levels of people with high social capital have higher levels of social engagement, levels of trust within their group, and norms of reciprocity. Okay, you do something for me, I'll do something for you. Now, one way you develop social capital is by participating in social institutions. And Putnam argued, and other researchers have demonstrated this, that especially in the US, kind of opportunities for collective social engagement have decreased, in both secular and non-secular. So for secular, like in general, like declines of unions, the kinds of like things like a bowling league, or like just opportunities to like come together as a group, and like meet your community. And then at like a non-secular levels, kind of like a decline of like church participation, which those kind of religious institutions serve as an opportunity to bring people together and kind of create social bonds and develop networks of people. So basically, you're seeing declines in kind of social participation, social groups, literally, really like friendships and social communications among people in the U.S. for decades. And then Putnam is going to argue that this decreases social capital, at least for specific groups. And two forms of social capital we want to discuss here quickly is bonding social capital, wherein we're really kind of looking inward within our groups and in an effort to bond our community together. We want to have strong kind of interpersonal trust within us, which can obviously be good, but also at the same time, you can imagine like very, very I don't know, like a nefarious like group or something like that, or like an elite group or something that's like super socially isolated, but they have like very strong interpersonal trust and norms of reciprocity within that group, and are kind of working together as a collective to, I don't know, achieve whatever it is you're trying to achieve at the expense of other people. So this is kind of the bonding can be positive and it can be negative. These kind of things are never just like straight, just binary black and white situations. Depends on the context. Which brings us to bridging capital, which refers to bridging or linking with diverse groups and providing opportunities for community members to access power. So in this case here, you can imagine, again, like a well-off, like a, I don't know, like a classic club for, I don't know, like people in high SES or something like that. And again, they can have that strong bonding social capital wherein they all trust each other, they have norms, they have all things that they're all striving for, but that can contribute to kind of poor public policy or something along those lines. Here, though, bridging social capital refers to kind of using your social capital to bridge to other communities, network, to then give them access to power and resources. So again, this can be whatever, high SES reaching out to low SES, or low SES groups working with other low SES groups across race, sexuality, gender, country, whatever, something along those lines. Let's look at a study on social capital, specifically a researcher who sampled church-going Latinas in California, that is Martinez in 2013, explored the relationships between leisure/physical activity and social cohesions. Promotoras are community health leaders who help with the dissemination of health information to community members, locally based and have very similar characteristics to the target population. Leisure physical activity and neighborhood cohesion were assessed at baseline, so basically right when the project started, 3 months and 6 months after the implementation of the pilot intervention. This intervention trained people on how to lead walking groups, providing them general information on the health benefits of physical activities and information on the barriers to and facilitators of physical activity. The evaluation of this intervention showed that social cohesion was an important predictor of physical activity. That is, social cohesion at 3 months could predict levels of physical activities at 6 months. The authors also suggested that it is possible that the promotoras enhance social cohesion by providing participants with a sense of belonging and a friendship while facilitating these activities. So here we have the researchers operationally defining or measuring social capital through social cohesion with these groups Latino women within California, and basically trying to identify predictors of physical activity, engaging in physical activity, in this case, walking groups. So here we had researchers kind of training some of the church-going Latinas to lead a walking group, and also give them information about the benefits of walking and exercising, and also some of the barriers faced by their community to engaging in physical activities, and also identifying facilitators, aka that promote physical activity among all people and specifically within their community. And what the authors found was, or they interpreted the results as, is that these groups increased social cohesions within the participants. That is, they increased their sense of belonging. They felt like they were part of a group. They had that bonding social capital, wherein they're kind of developing levels of trust and norms of reciprocity with each other. So, like, oh, I come out this week, you're going to come out this week, or oh, you have an issue that's preventing you from coming out, maybe whatever, a car, transportation. Well, I'll come and pick you up, something like that. And that increased sense of social cohesion was correlated with increased levels of physical activities at 6 months into the study, which suggests again that increase of belonging, friendships can help facilitate activities, specifically physical activities, aka this walking group. Community mobilization and power. Nidge 2010 argued participatory and community-based approaches that involved community participation can help to address issues related with poverty and health by empowering individuals and communities more widely. There is a need to transfer power relationships, according to Ansel, not just at the individual and community levels, but at the macro level. So basically what the researchers are arguing, and you see this a lot, kind of indigenous research and other kind of historically marginalized groups or former colonized populations, this idea of empowerment. Contributing to more positive health outcomes, because empowerment is associated with kind of just meeting the needs of that community, and meeting the needs of that community is going to be associated with more positive of health outcomes. So as such, kind of the argument is kind of using these community-based approaches and community participation to empower people, empower communities to change their social, environmental, developmental context. An example of this, Sheb and Likes in 2013 facilitated a participatory action and photo elicitation research project in post-Katrina New Orleans from 2007 to 2010. 11 African American and Latina women took part in the project. The findings suggested that in developing ties and new ways to respond to the consequences of a, quote, unnatural disaster, the participants developed intra- and inter-group empathy and the capacity to critically examine the social and structural determinants of health inequalities. So kind of the idea here is that we have this research project wherein we have the groups of racial minority, ethnic minority women who were exposed to Hurricane Katrina. So what these researchers did was had these women participate in a series of workshops wherein they took photos of the damage from Hurricane Katrina and kind of did almost like a little community investigation of the impact of Hurricane Katrina, what communities were impacted the most, and then kind of work in a collaborative effort to design what the next steps of the project would be, and ultimately translate this research findings into kind of some kind of social change. And as stated, what the researchers found was that this kind of process increased kind of intra, so within kind of the ethnic groups, empathy, and inter, that is between groups, empathy, and also the increase their capacity to critically examine determinants of health inequalities. That which brings us to this unnatural disaster point, and that is many researchers make this kind of arguments of who look at kind of the impact of natural disasters on health outcomes, aka dying from a hurricane, from an earthquake, or being left behind or experiencing the worst kind of consequences of a natural disaster. And what the research suggests is that there are certain groups, aka groups that have been historically disenfranchised, aka disabled people, racial minorities, lower class people, who are more likely to be the principal victims of these natural disasters. So they are stuck behind. They cannot evacuate because they lack have lower levels of social support, financial resources. They physically cannot move, and therefore they are hit with the worst excesses of any hurricane or any natural disaster at a disproportionate rate. So it's not that the natural disaster is like not real, like Hurricane Katrina existed. It's that the victims of a natural disaster are quote unquote not natural, but placed there. These are kind of social choices. Those are people who have already faced a high degree of cumulative risk factors, and now are more likely to be exposed to the worst aspects of a natural disaster. So that's what they mean by natural disaster. or I should say unnatural disaster. And with that kind of new knowledge, theoretically using that knowledge to, advocate for some kind of social change or seek to remedy those historical disenfranchisement. Next, Aveling and Jovacevich. Sorry if you're watching this, Jovacevich. I did my best. They argue that developing partnerships for health and community development, quote, must be understood not as a tool for intervention, but as part of the intervention and definition of success. The process of building partnerships involves critical reflection and is influenced by institutional and social cultural context. So basically what they're arguing is kind of like how that psychology conference already discussed, is that community development cannot just be seen as a kind of like this thing to the side, its own separate silo that you can deal with once in a while, but rather a kind of integral, a necessary part of all intervention success from a public health design perspective. Well, Vaughan in 2014 argued that while facilitating critical thinking is useful, the process does not inevitably lead to action, thus highlighting the need to shift the focus of participatory research from supporting, quote, safe social spaces to supporting, quote, transformational action in context. So basically, this is the classic argument of like the solution of like raise awareness, and then it's like, okay, well, what does that actually mean in like practice? So just like kind of increasing critical thinking or raising awareness does not actually necessarily automatically lead to transformation of the social conditions that are implicated in health inequalities, but rather you need to change, or I should say, accordingly, you should thus design research, design institutions, or whatever, encourage action that looks to change that development context more directly beyond kind of like neutral kind of ideas of like critical thinking or like awareness or something like that. So this is kind of like he's like calling out like other researchers that you'll see at like the end of most research studies, like, and therefore we just need to raise awareness, which is like an end goal of itself rather than like raise awareness and then what is kind of like the critique from Vaughan here. And then finally, our final critique of social capital is from Baum, 2000, who emphasized caution that there are dangers that the promotion of social capital may be seen as a substitute for economic investment in poor communities, particularly by those governments who wish to reduce government spending. So basically, the argument here from Baum is saying, yes, social capital matters, these inter-community links matter, but it is not a substitute for kind of alleviating poverty, which is implicated and a predictor of typically the strongest predictor, just abject poverty, of numerous health outcomes. So basically the argument here is, yes, you can analyze social capital, these kind of social links matter, but they either have to be used to transform, reduce poverty, or otherwise, you're just kind of just maintaining the status quo. Very similar argument to like Vaughan. These researchers, who critique these kind of methods, more psychosocial approach methods, or kind of like just raise awareness, safe social spaces, like critique people. They're basically always arguing like, yeah, these are just kind of like solutions that are not sufficient enough to decrease the health inequalities that exist between countries, formerly colonized countries, and the Western world or global North, or even within countries. So like people in high SES and low SES is basically the argument here. All right, so that's all for this week. Thank you so much for listening, and I hope you have a great week. Bye.